Lovely. Right. Hello, everyone. Thanks for joining us again for our actually third themed month this year. So our themed, as you would know from our communication over social media, is on infectious diseases. So today we're so lucky to have Professor Pam Vallely with us for a live Q&A session on infections happening before birth and the consequences of these, the problems that they might cause during pregnancy. So before we start learning about this topic, I would like to introduce the structure of our Q&A sessions to those who are new to our platform. So firstly, we are going to spend about half an hour going over some questions with Professor Vallely, and hopefully she will be telling us about, how we can manage these infections and what are the consequences of these infections. And after this, we will have a 10-minute comfort break and resume back for a Q&A session afterwards. During this break, I will be collating the questions that you submit through our social media accounts and on our YouTube channel, and I will be asking these questions on your behalf. So when we are having the discussion with Pam, please feel free to submit those questions as they come to your mind as we go along. So before moving on to our discussion, I would like to briefly introduce Pam. So Pam is a professor of medical virology at the University of Manchester, and after completing her PhD at the University of Sheffield, she moved to Manchester where she worked as clinical scientist in the NHS. And during that time, if I recall correctly, she was heavily involved with the patients who were actually HIV infected because of the blood that was being transported to USA without proper checks. And then after her time in there, she then moved to university as a lecturer and lecturing in virology, and she has been a professor in here for a long time now. So Pam, thank you for joining us today. It is an absolute pleasure to have you with us today, and we're looking forward to hearing about your research in medical virology.
Well, thank you very much for inviting me. I'm delighted to be here. Yeah, I mean, my current research is based around congenital viral infections, so viral infections that mum passes on to the baby before the baby's born. I'm particularly interested in cytomegalovirus, which I hope I'll answer some questions and tell you a bit more about as we go through the hour. I'm passionate about it because I think it's something that we all need to really understand much more about. It's such a common infection, and there's lots we can do about it, but we need more research, really.
Lovely, thank you. So to start with, though, obviously throughout your career, I'm sure you come across with many types of interesting viruses. So what has ignited your interest for this field specifically?
So it's interesting. I did a kind of a general biology degree in Liverpool as an undergraduate. But during my time as a student, and then I went on to do a PhD. It was really at the time when HIV was really coming to the fore. Okay, so there were lots of headlines in the newspapers, and this was the first time, certainly in my experience, and I think in a lot of other people's experience, where an infection caused by a virus had really impacted on people's lives to a great extent. Obviously, we can go back to the flu pandemic in 1918 and earlier, things like that. But it was a real moment of understanding the power, if you like, of a virus and how it could affect every aspect of people's lives. So I think that's what really made me concentrate on virology and become interested in viruses.
Okay, lovely, great. Thanks for that. So how do you think the public has been perceiving clinical virology over the course of your career? Did you see any change in the interest or appreciation of clinical virology? Can you tell us a bit more about that?
Yeah, so I would say the last year has seen a very big change. Prior to that, virology is quite a small discipline. Okay, so if you compare it to immunology or hematology, there are many more scientists working in the NHS in those areas than there are in virology. Virology tends to be quite small. And it's a relatively new science. Probably we didn't really have virology before about the 1960s. That would have just been part of general microbiology. But and so I would say, I used to say, people used to ask me what I'd do, and I'd say I'm a virologist, and they'd sort of say, oh, what does that do? Now, of course, everybody's a virologist. So people who might have classed themselves differently previously are now go on the radio and call themselves virologists. I've noticed a lot of that going on. But I think the understanding of the general public about virology, so most people now know what the structure of coronavirus is, basically. Most people sort of know about antibodies and things just from listening to the news. So I think the pandemic has had a huge impact on the perception of virology. And I think that it's clear now that we need more virologists. We need to increase this as a science. We need to be prepared for things like this in the future, and people need to be much better informed and educated. So I think virology now is going to really grow as a science.
Okay, so in terms of, and that just brings me to the question, in terms of funding opportunities and relative to other fields, do you think there are enough funding support or funding calls that you can apply to? How do you normally get your research funded?
Yeah, it is difficult. I think there will certainly, again, very recently, there's been a lot of funding concentrated on COVID, but that really, to be honest, is coming to an end. Studentships, MRC will fund some studentships in virology, but they are few and far between. There are a few centres of virology around the country, and they do tend to have some studentships as well. In Cambridge and Bristol has quite a strong virology. But I think now, again, that's going to be changing. So, BBSRC and MRC, when they're advertising, when they give studentships for doctoral training partnerships to universities, I think the impact of virology in the projects that are funded is going to be much bigger, because clearly we've amplified the need and we've shown the need now. So I'm hopeful that funding will increase for virology projects.
Yeah, hopefully. It is, this incident, this pandemic that we've been going through has just been a clear example of why we need it and why we should be prepared, I think. So hopefully things will start improving. So so you particularly focus on currently a group of viruses called cytomegaloviruses.
Yeah, cytomegalovirus is one of the herpes viruses. So yes, I have a general interest in herpes viruses anyway, but cytomegalovirus is the one I'm really keen on.
Okay, so why amongst the other herpes viruses this one then?
Or we shouldn't anthropomorphize. But one thing to get across is viruses are not living things. Okay, viruses are not alive, but it's sometimes difficult not to anthropomorphize a little bit, because cytomegalovirus is a really clever virus. If you want to put a human characteristic on it, it's one of the best adapted viruses of all. So if you think about it, a virus that comes along and kills lots of people, that's not a very successful virus. A successful virus is one that is able to live, replicate itself, move from person to person very efficiently, but not kill its host. Okay, because obviously that's limits the number of new hosts for it to go to. And cytomegalovirus has managed to evolve that to a great extent. So it lives in partnership, if you like, with the immune system generally. It's got lots and lots of genes that code for things that damp down the immune response, but it is able to live and let the cell replicate itself quite easily without doing any damage in most cases. And you can see what a fine balance it is, because as soon as somebody is immunocompromised and hasn't got a functioning immune system, then generally cytomegalovirus will cause serious disease. So my admiration, if you like, for cytomegalovirus is the way that it's adapted to live alongside humans, and it only infects humans, human cytomegalovirus.
Okay, all right. So is there any ways that we can actually, I'm sure we've got lots of knowledge about this virus. So is there any ways of treating this or vaccinating against this virus at all?
So treatment, first of all, there are effective treatments against cytomegalovirus. So there's a drug called ganciclovir, for example. There's a few others as well. And they're pretty powerful against cytomegalovirus if you give them to adults. Okay. The problem with giving them to very young children is that they cause, they're quite toxic. So they can cause problems in the blood and they can make the baby quite sick. Now, if you know that a baby is definitely affected by the virus and is going to have long-term permanent consequences, then it's worth taking that risk and balancing it and monitoring it very carefully. But what you can't do is to just any baby that's born with cytomegalovirus, most of whom will be fine, it's not ethical to give them ganciclovir because the harm that the drug will do outweighs the risk to the baby, if you like. So that's why we really need to know which babies are going to be severely affected before we start to treat them.
Mm-hmm. Okay.
In terms of vaccine, again, have been several vaccine candidates over the years for cytomegalovirus based on various things, and some of them have been fairly successful. One of them has got about 50 to 60% efficacy in preventing cytomegalovirus infection, but none of them have really been very much better than that. But again, there are trials going on now to try and see which, to test out new formulations for vaccines to try and prevent cytomegalovirus infection, or at least, if not prevent it, then stop it from doing harm.
Okay, all right. So I'm going to move towards, the babies, pregnancy and how CMV usually gets transmitted, though. Considering that we have evolved in such a way that you have to go through some barriers before you can actually reach to fetus. So, when we have got all of these things, how does it actually overcome all of these boundaries and reach to the baby, and how does it usually get transmitted?
That's a great question, actually. So cytomegalovirus is transmitted in any body fluid. Okay, so it's transmitted in urine, it's transmitted in saliva, it's transmitted in a cough, in blood, and also in sexual fluids. Okay, so in semen and vaginal fluids. It's most usually transmitted to children. So most people, a lot of people will get a cytomegalovirus infection in early childhood. And the most typical way that it gets passed on is that, a baby or a toddler comes along and granny comes along and gives the baby a kiss and a cuddle, and saliva gets transmitted from granny to the baby, and the baby picks up cytomegalovirus. But again, asymptomatic in most cases. They don't even know it. So the virus is passing from person to person easily. As I say, it can also be transmitted sexually, and it can be transmitted in blood products. Okay, although as long as you treat a blood product with some heat, then that will destroy cytomegalovirus. It's quite easily destroyed. So blood's not a typical way that it's transmitted in blood transfusions or things like that.
Okay. So can you actually get, let's say, if one person is CMV positive, can you actually get the virus transmitted into your sex cells, into your gonads? Is there a possibility for that, or is it always an external transmission infection?
Oh, I see what you mean. Sorry, no, yes, no, it's not passed on in the embryo. No, it's not passed on in the gonad, in the do I mean gonads? It's not in the sperm or the
reproductive
egg.
cells.
No.
Yeah.
Yeah, no, it's not.
All right. Okay. All right. That's quite interesting.
So
So obviously, you said obviously the viruses need to evolve in a way that either they are asymptomatic or the symptoms that they're giving to people are not going to cause them to die. But why, for a virus not causing any illness is almost hard to believe. So why or how CMV doesn't cause illness in most people?
so it's it does cause a lytic infection. So the virus infects somebody for the first time. Typically what happens is that the virus goes throughout the body and it will infect lots of different types of cells, and it causes those cells to lyse, but the immune system sort of brings it back under control. And so I say it doesn't cause any disease. Occasionally, in some people, it will cause a kind of an infectious mononucleosis-like illness during the primary infection, similar to Epstein-Barr virus, which causes glandular fever. But cytomegalovirus typically doesn't cause that because it's got this good balance. So it's able to infect cells. It's got lots of genes that it sort of damps down the immune system, because a lot of the symptoms that we see from viral infections are actually caused by the immune system rather than the virus itself. So because cytomegalovirus is able to kind of regulate the immune system with its own gene products, then often no infection is caused at all. But then that works the other way around as soon as the immune system stops working, because then all of these genes that cytomegalovirus is employed to kind of modulate the immune system then force it down even further, and then the virus just replicates and takes hold and causes lots of disease in the lungs and in the liver and even in the brain.
Okay, thank you. So in this case then, so can you tell us a bit about, you touched on it anyway, with the symptoms that it can give to people, but are there any other conditions or diseases or symptoms that they cause in pregnant women or in embryos, the babies? And can you tell us, give us a bit more information on those type of symptoms that are specific to babies that aren't born yet and their mothers?
Yeah. So again, it's an interesting thing about cytomegalovirus that after you first become infected, then because it's a herpes virus, it stays forever. So it remains latent in your body and it reactivates every now and again and gets shed in saliva or urine or anything else. So in a mother who gets the infection for the first time during pregnancy, okay, then the virus will replicate in her and sometimes will get passed through her placenta and into the fetus. Okay, now when it happens during the so-called primary infection, so the first time the mother's ever been infected with cytomegalovirus, then generally the symptoms for the fetus are quite bad. Okay, if the fetus becomes affected, and the typical symptoms are hepatosplenomegaly, so they'll get an enlarged liver and spleen. The virus typically gets into the brain and it causes calcifications in the brain. It causes microcephaly, so the brain doesn't develop properly, and it can affect the heart as well, and it travels into the brain and it gets into the inner ear and it causes deafness. So typically it affects the eyes, causing retinitis, the ears causing deafness, and the brain causing microcephaly and calcifications. And then there's these other sort of more symptomatic, more systematic symptoms like enlarged liver and spleen, but usually they can get better. And when the baby is born, often it will have a rash. It's called a sort of a red purpuric rash that's typical of cytomegalovirus and some other viral infections in the womb. Okay, so that's a really serious outcome of congenital cytomegalovirus infection. But interestingly, a woman who's already got the virus, okay, so it's latent in her body and it just reactivates again. And we used to not worry about those women at all. We used to think, well, they're not going to pass the virus on to the baby because they've got antibodies. But we now know that they do pass the virus on to their baby, okay? And in fact, because there's so many more women who are seropositive or who already got the virus, then actually the biggest burden of disease, if you like, is with that group of women, and they pass the virus on to the baby. Again, most of the time those babies are going to be fine, and even babies who are affected are going to be much less severely affected than one that's been infected because their mum's got a primary infection. Does that make sense?
Yeah.
Okay, so the most common symptoms in those babies who've got the virus from their mum when it's been reactivated in the mum is hearing loss. Okay, sometimes it affects the eyes as well, but we estimate that probably about a quarter of those babies will end up with some form of hearing loss. That's the most common symptom.
Okay. All right. So, considering all of these negative effects that it has on the health of the baby and the health of the mother, does pregnant woman routinely get tested for CMV infections so that a management plan can be put in place in the NHS?
No, and the reason for that is, well, there's lots of connected reasons. So there are a few places. So Israel does have a maternal screening program, and in the United States there are some states that are piloting some screening programs. The reason that it hasn't been adopted here and in most areas of the world as a screening program is that only around about 1 in 100 to 1 in 150 babies who is infected with only about 1 in 100 to 1 in 150 babies will be infected. Okay, and of those babies, so the 1 in 100, shall we say, babies that is infected, only about 10% of those will be severely affected. So we're looking at maybe 1 in 1,000 babies who's going to have a problem from this. Okay. So and until quite recently, there wasn't really an awful lot that we could do for those babies. We do now know that we can treat them quite successfully with ganciclovir as long as it's carefully managed. Mm-hmm. So we're in a situation where you're going to tell a mum that her baby is cytomegalovirus positive, mm-hmm. but most of the time that baby's going to be absolutely fine. There's not going to be outcome from it, so you're going to be worrying the mum perhaps unnecessarily. The previously again we weren't really able to offer anything for the baby to treat it. So putting it bluntly, economically and ethically, probably it wasn't really worth doing. I think that's changing now, and I think we are getting to the point where there is a good case for a screening program for cytomegalovirus, particularly if some of my research becomes adopted, in that if we could both test for the virus and show that a particular strain of the virus was more likely to cause a problem, and therefore you could treat that baby.
Okay, interesting. So considering, let's assume that one person got pregnant and their first child, they had a CMV infection and they infected their first child. Are there any studies done to identify whether or not how likely that person is to infect their second or third child?
I'm not aware of any particular trials that have focused on that particularly, but everything we know about cytomegalovirus would say that the second baby is very unlikely to have any problems. They may become infected, but they're very unlikely to be affected, because by that time the mother will have antibodies, so she'll have some the baby is not likely to have that problems from the primary infection. There's a theoretical chance that the baby could become infected again, but its symptoms will be likely to be much, much less.
Okay, all right. So in terms of the babies that are born then, would you say that they're more likely to develop? I know you touched on this previously, a few questions earlier, but I want to just reiterate the point in here. So do the babies who are born with the CMV infection, do they always develop symptoms from pregnancy and birth, or can they actually develop symptoms later in life?
Yeah, so again, particularly with the secondary infection, so the less serious one, if you like, the hearing loss often doesn't develop until months or even years after birth. I think the latest one I've ever read about was an 8-year-old girl who had been infected at birth but only developed hearing loss later. And hearing loss is a difficult one, as again, brain infections where it might cause impairment of intelligence later on. Sometimes those things are not always picked up until the child is old enough to talk or the speech doesn't develop properly or something like that. So it's difficult to pinpoint it exactly at which point it happens, but there have been studies that have identified children who've developed hearing loss at 2 and 3 years of age and then gone back and tested the samples that were taken from them at birth and shown that they were infected with cytomegalovirus.
Okay, all right. So can you think of any, if this CMV screening sort of program gets put into place, can you think of any preventative measures that can be put in place to prevent any symptoms or any problems happening later on?
So if the screening program was in place, then certainly a positive baby could be investigated further. A baby who tests for cytomegalovirus and is positive for cytomegalovirus, they could be screened, given regular hearing screening tests to look out for any problems that are developing. If the baby is definitely infected at birth, then you can treat for a limited period with a toxic drug and just monitor the toxic effects that it's having.
Okay, so I would like to move a little bit into your research area specifically. I know you work on CMV, but the literal research projects that you're running. So in your work, where you look at antiviral surface treatments, do you think this type of agents where you're actually trying to develop these surface treatments as antivirals, do you think this would be applicable to other viruses like influenza or even COVID, or do you think this would only apply to the CMV viruses?
No, so the work that we've done on antiviral, lots of antivirals actually, although there are some applicabilities to cytomegalovirus, really that work was sparked by the COVID outbreak, because what we've been doing is testing different surfaces to see whether, when viruses land on them, that they're destroyed or their efficacy is at least reduced. So that's got implications for lots and lots of viruses, particularly viruses like cytomegalovirus, like SARS-CoV-2, and like influenza, that have got lipid envelopes around the outside, because those viruses can be treated or can be destroyed by chemicals much more easily. So, hand washing does a good job as long as you use soap or alcohol gel, because it destroys the envelope of the virus and kills it. Similarly, antiviral sprays and so on, all of those things will destroy the viral envelope and help with infection control. My own research with cytomegalovirus is based around the glycoproteins that are stuck in that envelope, and what we're trying to do is see whether the mutations in those glycoproteins are make it easier for the virus to cause a severe disease in a baby.
Okay, so some of the audience might not be very familiar with glycoproteins. So can you please maybe explain it to us in a bit more basic, with a bit more basic language, and tell us a bit more about your research in the field?
Sure, yeah. So glycoproteins, glyco means sugar and protein is a protein. So a glycoprotein is a protein that's got lots of sugars stuck on the outside. Now, the main function of proteins that viruses use that are stuck in their envelope like that is to allow them to get into cells. And we've heard a lot from around SARS-CoV-2 about the spike protein. So the spike protein binds to the receptor on a human cell, and that acts like a lock and key to get the virus into the cell. Okay. So in terms of cytomegalovirus, so SARS-CoV-2 has really got this one spike protein that it uses to get into cells. Okay, cytomegalovirus is different. It's got lots and lots of these glycoproteins on its surface, and it uses them for different things. Some of them it uses to get into the cell in the same sort of lock and key way, and others it uses to transmit from cell to cell and do other things within the cell. So the interesting thing from my research about what cytomegalovirus is able to do is that those the gene or the genetic code that codes for that glycoprotein has a tendency to have lots of mutations in it. And when you get a mutation in the genetic code, then when the code is read and the protein is made from the code, the protein is slightly altered in shape. And when you get a slight alteration in the shape, then sometimes it doesn't fit as well into the receptor. And so that means that it becomes less good at infecting cells. But other times it changes shape so that it fits even better into the receptor, or it's able to fit into another receptor that it couldn't use before. And so that makes it easier for it to get into a cell, or it makes it easier for it to get into a different cell type that it couldn't get into before. So what we're doing is looking at how those mutations in the glycoproteins on the surface of the virus are able to help it or hinder it getting into the cell and causing an infection.
Lovely. Thank you very much. So sorry for bombarding you with questions for the last hour. It has been 30 minutes now, and I'm sure you would appreciate a break. So shall we break for 10 minutes and resume back at 7:10? Okay, great. Well, thanks very much, Pam, for this informative session. And now we have got the questions from our audience, so I would like to start going through these. So before the session, one of the audience has sent us a question which is not directly related to CMV viruses, but it is a very relevant question for today, I think. So they're asking on your opinion on pregnant women receiving any of the current coronavirus vaccines.
Yeah, so it's, as a general rule, you avoid vaccinating somebody in pregnancy if you possibly can, okay? And the only reason for that is that you avoid giving any drugs or anything else during pregnancy, because you just, there's a small chance. However, for this particular vaccine, I think the dangers to pregnant women of catching COVID are probably far greater than for the vaccine. I think there are studies going on to collect an evidence base to say, whether it's safe to vaccinate a pregnant woman. But as far as I am aware, there is no, we're not aware of any reason why a pregnant woman shouldn't be vaccinated. But it has to be done on an individual basis and in consultation with a care provider really beforehand. The whole stuff that was circulating on the internet about the vaccine causing infertility is just wrong.
Yeah, it's amazing, isn't it? It sounds like they've done a test overnight and decided that that's the case. Yeah, so it's amazing how much these situations are being exploited by people.
Yeah.
So the other question again is on COVID as well. So why do you think COVID-19 or SARS-CoV-2 spread so far compared to SARS-1 and MERS? What do you think is the difference?
Yeah, so it seems to be that SARS-CoV-2 has got better transmissibility. So I talked before about the glycoprotein fitting into the receptor like a lock and a key, and it seems that SARS-CoV-2 is able to do that better and therefore spread more easily. And then the other thing that's really important about SARS-CoV-2 compared to SARS and compared to MERS is that it causes asymptomatic infection much more often. And if somebody's asymptomatic, they don't know they're infected, and so they can go about, usually if you're sick, you stay in bed or you confine yourself. If you're not sick, you go about your daily life as normal. Sorry, I'm just getting interrupted by somebody and dogs here.
Fine, no worries.
You go about your daily life as normal, and therefore you pass the infection on to lots of other people. But it seems to be around transmissibility.
Okay, so how do you think, when you consider that these viruses are dormant, when they're not in a living organism, when they are not living in a body that is actually living and breathing. So how do you think a virus can either gain that mutation that leads to more transmissibility? Or, why, if this is this much transmissible, why didn't we have SARS-CoV-2 infections before SARS-1 and MERS, if that makes sense?
Yeah, so the best, there's several theories for how it arose. Now, we know bats are a rich source of viruses that, like coronaviruses. So it seems that the reservoir, if you like, for SARS and other coronaviruses are bats. And exactly how the virus got from the bat to the human to cause this deadly disease is not fully understood. But what we think happened is that the virus went from a bat into an intermediate species, and a pangolin is the one that's most often talked about in relation to SARS-CoV-2, and then from there into humans. But every time a virus replicates and goes through a replicative cycle, a life cycle, then it will mutate, especially an RNA virus like SARS-CoV-2. So every single time it replicates itself, there are mutations being introduced. Now, oftentimes those mutations will make the virus no good. It won't be able to carry on. But occasionally, one of those mutations will be something that makes the virus better and fitter. And what's quite likely to have happened with SARS-CoV-2 is that it's been circulating, getting fitter and fitter and fitter as time has gone on. And really, once it got to that kind of optimal point, it got into the human population, and that's what allowed it to spread. So these sort of events are happening all the time. It's just that every now and again, very, very, very rarely, as has happened with SARS-CoV-2, it takes off and it causes something that we've never met, we're not immune to. It spreads throughout the whole population really quickly.
Okay, so how long does it normally take for a virus to start being transmitted between species? So how long do you think SARS-CoV-2 has been evolving in the background until it caused this sort of problems?
I think that's really difficult to say. There are genetic studies, so people who do a lot of work with bioinformatics, and as time goes on, we will be able to get lots and lots and lots of viruses from different time points and try and compare all of those to see how it has evolved. But I think that's impossible to say, and it really depends on what the mutations are, how well they adapt. It's purely chance. It's completely random. So there's no way of saying it takes X amount of time to cause a problem virus.
All right. Okay. Thank you. So another question is coming from a healthcare professional. So they're saying that they find that they do not get much education around virology. Is there any work going on into this? And what are the best resources to educate ourselves?
Yeah, I completely agree with you. I think that there's a lack of, there has been a lack of virology in the medical curriculum and lots of other curricula for quite some time. I'm hoping that, again, the pandemic may change that. I'm heavily involved in master's courses and undergraduate courses. We need more virology. As I said, it has been quite a small science, and I think the importance of it is changing. Certainly, I found that as a virologist, I've been much more in demand than I've ever been in my life over this last year. So I think a lot of people are understanding the importance of teaching that basic virology so that people can understand it. It's how important is it for a GP to be able to understand how a viral infection works, in hospitals, in accident emergency, all of those areas. It's really important to understand the implications of a viral infection and what it can do.
Yeah, great, thank you. So do you know then if this current climate has actually caused people to start thinking about additional curriculum items for medics, or do you think it's just one of those things that is going to be discussed and not actually get acted on?
Well, I guess with all of these things, that there are teams of people who review curricula and so on, and I'm certain that it will feed into that. Perhaps a small example: I run a master's course, and we have had probably 3 times more applications this year than we ever would get previously. So it's going to be demand led. So people are going to want to know about it, and inevitably that means that it should feed into the curricula.
Okay, great, lovely. And one last question, if you're not too tired. So during the talk, the discussion, you mentioned about routine screening programs in countries like Israel and in the States. So can you tell us how these routine screening is done? What methods are used? What needs to be done? Is it saliva?
Yeah.
Is it blood? And can you tell us a bit more about that?
Yeah, so there's a few methods. The simplest method is to use a dried blood spot. So many countries, including the UK, routinely screen babies for metabolic disorders by using a heel prick and something called a Guthrie card, and you simply spot a bit of the baby's blood onto the Guthrie card. That dries, and then that can go off and be tested by biochemical analysis for phenylketonuria and various other metabolic disorders. You could include cytomegalovirus into that screening program because, again, we know that you can test for cytomegalovirus using a dried blood spot. The problem with getting it adopted is that lots of people have tried it and there have been different levels of sensitivity. So people get different results depending on which laboratory it's done in. So that there needs to be some standards and some standardization around that, but that could all be done. The other way that you could do it is with a simple saliva test as well. So again, put a sponge or a piece of blotting paper into a baby's mouth, dry that, and you could again test for the virus from that. The important thing with being able to tell it's a congenital infection is that it must be detected within 3 weeks of the baby's birth. Okay, so if it goes beyond that time, then the baby could have acquired the virus after it's been born, in which case it's a postnatal infection, not a congenital infection. And in most babies, that again would be not a problem. The only babies that might be a big problem in are premature babies or babies who have very low birth weight, and they can then get problems with cytomegalovirus even if they've acquired it after birth.
Okay. All right, great. Thank you very much. So I don't want to keep you any longer. I think this is the end of the questions that we had this evening. It was a very interesting talk, and I myself have learned a lot. So thanks very much, Pam, and look forward to hearing from you in future again.
Thank you. It's been a pleasure. Thank you very much for inviting me.
Lovely. Thank you. And so I would like to say goodbye to our audience as well. Please keep watching this space. We have got a very exciting anniversary month planned by our volunteers, mainly by Josh. So keep your ears and eyes open. There will be lots of exciting opportunities for you to get involved with what we do at Live with Scientists. Thank you very much.